Yeah. But since they got my actual life is still fine. Okay, it's not gonna affect me much. It's the same Wi-Fi, just a different router. Okay, is the stream fine now? I think I got disconnected, and then the OBS, yeah, the webcam crashed as well. I feel like there's something's really wrong with my Wi-Fi today. It keeps disconnecting. Even in League, it disconnected. It's just painful. Let me just check my bitrate. Okay, bitrate's fine. It's running. Okay. Yeah, we're back. Yeah, I'm an Indian, but yeah, it's literally because not many Indians play League, so it's really hard to find Indian streamers to collab with. Because I have a lot of Filipino friends. I have a lot of Filipino VTubers and streamers who play League of Legends, but it's so hard to mingle with them because of their different dialect and language. Because they all speak Tagalog, and I'm like laughing in the background, but not understanding the joke at all. And the only thing I understand the entire conversation is if they shout "Bobo," and then I'm like, "Mahal kita." Mahal kita means I love you, and Bobo is gay. I'm like half Indian, but that's the funny thing. It's so niche, which makes it fun. So when I meet an Indian streamer, it's genuinely a fun moment. Great. Yeah, me too. I have a lot of Filipino friends. I visited Philippines last year to meet some of them. Crazy. That's so good. But I hope you had a good time. I have a lot of Filipino friends. I dare you not. I have a lot of medical Filipino friends as well who are VTubers. Yeah, but I do want to visit Philippines sometime. No, I don't know much sightseeing places in Philippines, but I do have way too many friends who are from Philippines. I think every day would just be roaming with someone. Of course, most Filipinos are nurses. No, he's a doctor. He's a med student. So medical is what almost all of them are. Well, I mean, he's basically an American, but with a Filipino background, and then he went to Philippines to study in Med University. That if I need to zoom in, just tell me because yeah, it's in the webcam's in a really weird angle. Doing something. Well, in India, yeah, I mean, you guys know there's only two options. One is the engineer. There are three options. One is the engineer, one is medical, and one is being a lawyer. You don't really have any other option in India for some fucking reason. It's the fucking old generation. And now all those three are so saturated, I swear to fucking God. Okay, wait, fibrinoid necrosis. So fibrinoid, so you see this is a vessel. What do you see the layers of the vessel wall? The mucosa, the muscularis layer, the serosa, and this is a vessel wall basically. Now we see how this muscle layer has undergone necrosis, or this because I don't know which layers is. Usually you have a very thin muscle layer. So this is nothing but fibrinoid necrosis of the vessel. See, I told you PAN. We discussed PAN yesterday, PAN vasculitis, where the mnemonic is literally just PAN. Then you also see in malignant hypertension with onion skin fibrosis and RHD. Now, okay, this we already discussed yesterday. These are councilman bodies or appropriate dark bodies seen in viral hepatitis. Where do we see councilman bodies? C for councilman, C for hepatitis C. Okay. Guys, I changed the schedule a bit. I updated into Discord, but I did not update on the rest of my socials. Yeah. Today we're gonna do a study stream, and then night we're gonna play solo queue. I don't think we're gonna play solo queue. I want to practice Gwen and normals. I want to have more games in Gwen so that I'm confident in playing her, because I'm really I don't know. It's so flippy. My games are so flippy. Like The first 3 games I just smoked it, but then against a set I struggled quite a lot. Set is really annoying to play. Okay, I beat pretty much anything. I can beat Yorick against set, but that's just because I learned to modify my build in such a way that set gets murdered. Plus, I just know how to play set against set with a Yorick. But that's because I don't really have to go in as Yorick. I just can E from outside. Set is pretty much weak against any ranged ability. I'm not gonna say ranged champion because I hate ranged top. I'm gonna say ranged ability like Yorick E with his tools. But Gwen has a good attack range, but yeah, she's still melee, so it's kind of you need to really trick the set into using his W. Yeah, I need to play more games. I need to play stuff against champs like Darius, Olaf, set to exactly know when to engage and how to engage onto them. So next we have Agro's Gel Electrophoresis. So A is normal. You see, it's completely black. This is white layer. This is normal. Now we have a step ladder pattern in apoptosis, and we have a smearing. See how smear? There's a tongue-shaped smear. This is smearing pattern in necrosis. Focus. Yeah, I'm trying. So caspases, intrinsic, we have C9, extrinsic C8, C9. You need to read that caspases table of the flowchart. Execution is by C3, C6, C7. So okay, easy to remember. C8, C10 is extrinsic. In between, inside C8 and C10, what is that? It's intrinsic. So that's C9. So we are done with 8, 9, 10. What is left? 6, 7. 6, 7 is execution. Along with that, we have C3. C3, even in coagulation and apoptosis, 3 is important. So 3 is executing, including and coagulation. Third factor is executing. So here C3, there coagulation 3. So next we have necroptosis. Necroptosis is caspase independent. So the only apoptosis which is caspase independent is necroptosis. Next we have pyroptosis. I1, C1, C11, 1. What's left is C1. So we discussed 3, 6, 7, 8, 10. Now what is left? What's left is 1 is left, 2 is left, 2 is nothing, 4, 5, and 11. So these all come under pyroptosis. And ferroptosis is phantom reaction, lipid peroxidation. Okay. Now we have sirtuins. What are sirtuins? Sirtuins are basically they are inhibitors of apoptosis. They increase longevity. So they're NAD dependent protein deacetylase. How do they increase longevity? By calorie restriction, low doses of red. So they're present in red wine. So low doses of red wine consumption actually has sirtuins, which increase longevity. I wouldn't say consume red wine on a daily basis, but I think low dose of red wine is still fine. I mean, there are researchers against it. There are researchers towards it. But yeah, there's this age-old tradition of drinking red wine to increase longevity. Then increase insulin it increases insulin sensitivity, prevents diabetes mellitus, promote and inhibits cancers, reduce cardiac hypertrophy. So low doses, I would say drink red wine. I'd say drinking low doses of red wine is good. It's a little side of good. It's still under research, but traditions say it's good, so I would not want to argue against it, but even medical is pointing towards the tradition. Also, if there's that one video which I made, yeah, facts was, you know, what is it? Myths versus facts or something, where I picked out various YouTube trends and spoke science against it. I'm still waiting. My editor said he'd make a short word of it, but he still hasn't sent it yet. I need to torture him a little. I need to fucking torture. I need to belt him. So mechanism of action is by decreasing apoptosis, free radical injury, activate DNA repair enzymes. Now we have stains. To stain melanin, we need M for melanin, M for Mason Fontana stain, which stains melanin as black color. For hemosiderin, we have Persian blue, which stains blue. Copper, we have rhodamine. Remember, rhodamine, I said, is for tuberculosis. So rhodamine and rubinic acid. Cellular plasmin is orcine. Fat is oil red O. You remember how adipose tissue is circular, the brown, so O, oil red O. Lipid deposit and heart is stained by Sudan black, SBB. Tabby type triggered. Then fresh tissue or frozen section staining is by oil red O, which is same as fat and lipids. And calcium, there's one CASA and alizarin red. Now pus. Treponema whipli is pus positive. Wait, what the fuck? I don't know what I scratched here. Oh, well. Okay, glycogen is pus positive, stain as magenta pink. Now myeloblast is MPO positive, myeloperoxidase positive, and Sudan black positive. Yeah, this is just, it's hard to remember if they put in this kind of tables. Myeloid I don't know, I'm used to reading them separately, that when you compile them like this, it just feels so pointless. Monocytes are non-NSC positive, M4, M5A, melanocite positive. T-all is acid phosphatase positive. Burkitt blast is Burkitt lymphoma blast. Lymphoblasts are pass positive or Sudan black. Okay, wait, it depends. Pass negative. What? Okay, this is something. No, they didn't give it clearly, but one of them is pass negative, SBB positive, and the other is SBB positive and pass negative. Wait, pass negative, pass positive, and SBB negative. Now, TTC is used in MI, mucin for mucin. You can do H and E, hematoxylin and eosin, and pass. Also, allicin blue. Next, we have amyloid, which amyloid is important. Congo red stain. Light microscopy, you see salmon pink color, and polarizing microscopy, apple green by fringence. The amyloid is Congo red stain, and light microscopy, you see salmon pink, and then polarizing or electron microscopy, you see apple green by fringence. Now, nature of the amyloid, this is another important table. Alzheimer's, you have A beta amyloid. I think it's A beta 2, no? Oh, wait, A beta 1, never mind. Multiple myeloma, you have AL. Senile systemic amyloidosis, ATTR normal. Familial amyloid polyneuropathy is ATTR mutant. Mediterranean fever is AA. A beta 2 is hemodialysis associated. I used to remember this very clearly. Now I'm just forgetting. I used to know this table by heart in my second year. Majority CAF, thyroid, ACAL, and chronic inflammation in TB is AA. So multiple myeloma AL, CRF for hemodialysis associated is A beta 2, Alzheimer's is A beta, systemic amyloidosis is ATTR normal, familial polyneuropathy is ATTR mutant, familial Mediterranean fever is AA pyrene. Next, we have I feel like ordering something and eating. What's the time? Lunch is in an hour anyways. I mean, we do have walnuts. I do feel like eating pizza, but we do have walnuts. And walnuts are addicting. I'm a squirrel. I'm a fucking squirrel. I'm a bunny squirrel. Bunnies are just bigger squirrels. Okay. Elastic fibers, Van Giesen stain, which gives black color, and has priority, as we already discussed yesterday. So, silver stripe stain, wooden silver stripe stain, which gives a black color. So, what you said, M for Marilyn, M for Mason Fontana, we with the black color. Hemocyanin, we already discussed yesterday, brown color, seen in heart failure syndrome, macrophages, hemochromatosis, lower heart failure, pulse portion blue. Then we have nutmeg liver seen in right heart failure, which is necrotic, dark red, pale is normal. So the pale part is normal, but the necrotic dark red is what you call the nutmeg liver, is the abnormal cells, necrotic cells. Then alcoholic liver disease, we already discussed, myelin body. Red perfusion, golden yellow pigment, erythroblast, lymphoblast, mercury blast. Nothing much. In fact, it's a pale part in this MI10. Now the sequence of inflammation. So vascular events is first vasoconstriction, then vasodilation, then increase in vasoactive peptides, then most common endothelial gag, post cell contraction, and then stasis. So cellular events is margination, rolling by selectin, CD62. You have P selectin, E selectin, and L selectin. L selectin within the leukocytes, P selectin is within the wall, and E selectin is what helps you adhere. Now, each has its own different role. So there's margination, then the neutrophils roll over the vessel wall, then there's adhesion by integrins. So when they're adhered, they transmigrate. So how does adhesion occur? By VCAM, ICAM, VCAM beta 1 and ICAM beta 2. Then transmigration by PCAM or CD32, CD31. Enzyme is MMPs. Enzyme is MMPs. Transmigration is by PCAM or CD31. And then there's chemotaxis. Chemotaxis is nothing but, as we said yesterday, IL-8 neutrophils. Then we have opsonization by C2B, C4B, C5B, all Bs. And personal IgG. Yeah, I should avoid eating too many poisons. I'm too addicted to these, and I have run out soon. I can't get these walnuts in India. My sister gets them from Dubai. Very good. They don't have that bitchy taste. And they're really addicting. They're so fucking addicting. Dry fruits in Dubai are so fucking addicting. I do not like dates. I do not like dates for some reason, but I love walnuts. It's give me this irony flavor I don't like. So phagocytosis is by NADPH oxidase. I really don't like this table. I have a better one. I'll read it later. So NATs, arginine deaminase, it's sepsis, prevent sepsis. Amino acid involved is arginine. I just said arginine deaminase, sertraline, arginine to sertraline. Excess NAT causes sepsis. Classical example of beneficials, you said. So this is the neutrophil trap. What's this? I don't like this. I don't like this part of cap at all. I hate gender pap. Who's that, guys? So where were we? Okay, mediators. The statement for functions are vasodilation in arterioles, vasoconstriction in the arteries, bronchoconstriction, vasopressure, increased vasodilation for histamine and serotonin. Next, you have neuropeptides, neurokinin A, substance B, which involved in pain signal transcription, and also increase vasopeptides. Now we have nitric oxide, which inhibits platelet aggregation and causes vasodilation. Then we have cytokines, fever, IL-1, TNF-alpha, PGE2. Cancer cachexia is TNF-alpha. Angiogenesis is vasodilated growth factor. Fibrosis is TGF-beta. Granuloma is IFN gamma. And what is APR? Wait, I think I know APR. I can't remember. Next, we have AA metabolites. Okay, chemokines, nucleoside activation or chemotaxis. Amino acid metabolites, COX and LOX. PGD2, PG2 vasodilation with Dashman, PGI2, thromboxane A2. So PGI2 inhibits platelet aggregation, whereas thromboxane A2 activates platelet aggregation. So PGI2, as we said before, with nitric oxide, same as nitric oxide, it inhibits platelet aggregation and causes vasodilation. Whereas TX8, thromboxane A2, it activates platelet aggregation and causes vasoconstriction. So PGF2 alpha, where does it act? As we know, it acts in the uterus. And others are smooth muscles and bronchus. Then hyperalgesia is caused by PGE2. E for eosinophil, algesia is PGE2. It's no stand for eosinophil, but that's what really how I remember it as. Because they have the same action. Then LTB4 is chemotaxis, LTC4, D4, E4 is vasoconstriction, bronchoconstriction, increased vasopressure. So the first one, B4, is for chemotaxis. The rest of them are for vasoconstriction, bronchoconstriction, increased vaso. Then we have lipoxin. Lipoxin is an anti-inflammatory. Then we have PAF, which is platelet aggregation, vasoconstriction, bronchoconstriction. So, but PAF in low doses causes vasodilation, with exactly opposite of its main function. Now, kinins. We have kinins, which is bradykinin. Brad E, it's in the name. It causes vasodilation, increased vasopeptide, and is the mediator of pain. Next, we have complements, which is C3A, complements, we need the table. C5B causes lysis involved in MAC. C3A, C5A, C4A, all the A's are amylotoxins, and already we discussed B is opsonizations. Now, TV granuloma, related to seizures necrosis, donor granuloma seen in clear fever, stellate granuloma seen in cat scratch disease. Stellate stellate. So it starts with an S as in stellate, S in scratch. So cat scratch disease. Now donut, Q is in the shape of a donut, so donut granuloma. Shaman bodies are calcium inclusion inside giant cells as part of granuloma. Asteroid bodies, we already discussed extracellular and intracellular. Extracellular asteroid bodies is seen in spirochetes, intracellular is seen in giant cells. Next, Dirk's granuloma is seen in cerebral malaria. Eosinophilic granuloma is seen in LCH. Dirk's granuloma, Dirk's dirty mosquitoes. Wound healing, we already discussed this before, but let's do it again. Clot 0. Day 0 is clot, day 1 is neutrophil, day 2 is neutrophil with thin layer, day 3 is macrophages, granulation push. Day 14 to 21 is maximum amount of collagen. Day 28 is type 1 collagen replaces the type 3 collagen. Next we have difference between normal epithelium and a dysplastic epithelium. See, it's normal cell, everything is normal. There is normal NC ratio. There's normal nuclear morphology. There's normal cytoplasm. There's no invasion of any cells whatsoever. Now look at this. Look at this. So there's dysplasia. There's pleomorphism. There's hyperchromasia. There's high NC ratio. And there's still no invasion. Very important. In this plastic epithelium, there's no invasion. Now, next we have anaplasia. Anaplasia is where you see invasion of cells. So since higher NC ratio again, this pleomorphism is there. There's hyperchromasia, but here you have mitosis and high mitotic index and invasion of cells. Now let's go to oncogenes, very important. Red gene you see in Hirschsprung disease, miliary thyroid carcinoma, MEN2. ALK, you see in adenocarcinoma lung, CKIT is seen in GIST, we discussed yesterday, ABL is in CML, ABL, CML, ALL, KRAS in colon cancer, pancreatic cancer, KRAS in colon cancer, pancreatic cancer, HRAS in bladder and kidney, and NRAS in melanomas. How are we going to remember? I have a very racist way of remembering this, but I'd rather not say. I just rather not say. Yeah, it's in my head now. It's just in my head. It's stuck in my head. They're not going to come out. Now we have Notch1 gene, which is seen in ALL and CLL. There's CMAC, which we discussed yesterday, which is seen in Burkitt's lymphoma and CA colon. There's L for lung, L for small cell lung cancer, and for neuroblastoma. EGFR, ERBB1 is seen in adenocarcinoma of lung. ERBB2, however, HER2 is seen in breast cancer. So EGFR is ERBB1 in lung cancer, adenocarcinoma of the lung, whereas ERBB2 or HER2 is breast cancer. BRAF is PTC, LZH, HCL. JAK mutation is in myeloproliferative neoplasms. Polycythemia, you have JAK2. Then essential thrombocythemia, you have JAK, CALR, and MPL. Then CDK4 is in glioblastoma, cyclin D1 is in mantle cell lymphoma, multiple myeloma. Now, tumor suppressor genes. Tumor suppressor genes, P53 suppression. P53 is in a lot of cancers actually, but common tumors are Lee-Fraumeni syndrome, HPV cervical cancer. RB, we already discussed, only two tumors involving RB gene mutation, that is retinoblastoma and osteosarcoma. P5017P red chromosome, whereas RB is 13Q. Now we have APC. APC is for mainly for familial adenomatous polyp associated with colon cancer, or the reverse actually. Colon cancer associated with FAP. Neurofibromatosis 1 and neurofibromatosis 2 associated with NF type 1 and NF type 2 respectively. NF type 2 also associated with schwannomas and meningiomas. I don't think problem is important for that. Now P10 is mainly, if they say P10, it has to be involved with an epithelial cancer. Like example, Cowden syndrome, then there's breast cancer, there's endometrial cancer, there's thyroid cancer. Now VHL, straightforward VHL syndrome. Then Wilms tumor 1, Wilms tumor 2. Wilms tumor 1 is chromosome 11 and Wilms tumor 2 is chromosome 13. Now Wilms tumor 1 is Wilms tumor, whereas Wilms tumor WT2 is Beckwith-Friedman syndrome. BRCA1 is breast cancer and ovarian cancer. BRCA2 is mainly associated with male breast cancer, which is more aggressive, and prostate cancer. Next, we have SMAT2, SMAT4. We already discussed that mnemonic 1, 2, 3, 4, which is in PJS. PGS or FAP, I don't know, one of them. I think FAP. Now we have SKT11, already I said yesterday, where PJP, you see in polyps. So I remember as KT1. Then CDH1. CDH1 is seen in diffuse type of gastric cancer and lobular type of breast cancer. Now we have in diffuse time we see signature, whereas Indian file pattern and breast cancer. Now MSH2, MLH1, MSH6 are seen in HNPCC or Lynch syndrome. Now we have translocations, Robertson translocation T1491, mantle cell lymphoma is T1114, follicular lymphoma is 1418, Burkitt lymphoma is 28814 and 822. ALCL is 25, AML M2 is 8. Okay, this is something I need to remember. I just forgot. Mantle cell lymphoma is 1114, follicular lymphoma is 1418, Burkitt is T2, T8, T1814, and T822. So there has to be 8, B for 8. If there is 8, then that's 4 kids. Now ALCL is T25, AMLM2 is 851. That's what that's okay. There's more. So let's go from down to up. Let's leave the methodology part at the end. Rhabdomyosarcoma is T113 and T213. E-wings is T1122. Synovial sarcoma is X18. CML is 922. AML M4 is in version 16. AML M3 is 1570. So M4 is 16. M3, imagine M3 is 1517. What is missing is 16. So 16 is in M4, which is in version 16. If AML M2 is 821. H21. 821. And what is left is 22, which is in AML. So 122. CML is 922. Next, we have alkalizing agents, carcinogens. So carcinogens for all cause work. This they ask very frequently. Alkylating agents cause lymphoma, leukemia. Aromatic amines like benzidine causes bladder cancer, whereas benzene causes blood cancer. So benzidine D for bladder. It's hard to remember. There are 2 Ds. I remember it has 2 Ds, but blood has only 1 D, so it's in benzene. Whereas benzidine, take like 1 D and put it in bladder with 2 Ds. The ethanol causes hepatocellular carcinoma, alcohol. Asbestos causes malignant mesothelioma, but most common is adenocarcinoma. Tobacco smoke causes squamous cell cancer of the lung, adenocarcinoma, small cell lung cancer. Then we have arsenic. Arsenic causes hepatic angiosarcoma and also lung cancer. Same with vinyl chloride and thiotrust. Now we have nickel, chromium, beryllium, silica, which all cause lung cancer. Nitrosamines are present in smoked food, which causes gastric cancer. That's why they say do not eat smoked food too much, and it's actually they're banning it in Japan now. Then benzene, as we said, blood cancer causes AML. Alpha toxin causes hepatocellular carcinoma. Now we have IHC markers, squamous cell carcinoma of they did not match. Okay, esophagus is P40, morbid P63. Adenocarcinoma of the lung is NAPSID A in India and the world, whereas in Asia, TTF is more common. Now, neuroendocrine tumors, synaptophysin and chromogranin, we already discussed yesterday. Oh my god. Calvitrin in mesothelioma, which is, we already discussed, the kid, dog 1. Intestinal adenocarcinoma, CT20, CTX2, glioblastoma, and oligodendro. Any neuronal tumor, you see GFAP, positive GFAP. See astrocytoma, you see Rosenthal, fibrous pseudo-rosettes. Then there's glioblastoma, oligodendro. All these have GFAP positive. Whereas meningioma has meant for meningioma and man for vimentin. That's literally how it went. Then schwannoma is again S for schwannoma, S for S100. Seminoma OC4 nano G. We already discussed this. Semen nano G. What is it? October 3rd. Then we have prostate adenocarcinoma. PSA, which every middle-aged person has to get it done. It's part of a comprehensive screening now. Then medullary thyroid cancer marker is calcitonin. Yolk sac tumors is always AFP. Endodermal sinus tumor is shielded body, which we discussed yesterday. Granulosa cell tumors inhibin called Leissner bodies. Now, hepatocellular cancer is this osteosarcoma. It's actually RB. Okay, Ewing sarcoma CD99, rhabdomyosarcoma is desmin, myogenin. Now we are getting into genetic studies. This is actually really fun, in my definition of fun. So we have a 2G rule. So gender, male, female. If it's present both, it's autosomal dominant. So all generations, it's present, it's dominant. If it's a skip in generation, it's recessive. Now 2G rule applying to each. So we are talking about autosomal dominant. So dominant, all genes are present. So how do you say it's autosomal? Both male and female are affected. It's autosomal. Now 2G rule in autosomal recessive. Autosomal, that means both male and female should be affected. It's recessive, so one generation should be skipped. Next we have 2G rule applying to X-linked dominant. So we said dominant. So dominant means all genes should be present. Wait, what? Okay, this is okay. All generations should be present. That's all. But here, since okay, since it's dominant, there's gonna be present. Since it's X-linked dominant and X is present in both X, Y, so all both male and females affected, and it's affected. It affects all generations. So fathers to daughters, fathers to every daughter, and mother to 50% of the offsprings, because there are two X, only one X gets transmitted, and if they're heterozygous, then one X should be normal, and that X, because of that, there's only 50%. Now X-linked recessive, only males are affected, and one generation is skipped. Now we have Y-linked. Y-linked affects only males, and all generations are affected. Mitochondrial inheritance is from the mother. So if only mother is affected and mother to all children and fathers are not affected, then it is mitochondrial inheritance. So now let's take an example. So let's look here. So mother, father. So all children are affected here. So what can this be? This could be an X-linked, because why do I say it as X-linked? What the fuck? Okay, why do I say this is X-linked? Just because, 1 second, guys. Okay, I say this is I think this could be an X-linked. I don't wanna fucking jinx it. So look at this. Every generation is affected. It could be X-linked dominant, but then you look at this X-linked. This could be X-linked recessive because not all generations. So this is a little confusion. This could be anything. Now let's trace it. So the mother is affected. The mother is affected. That means it could be mother is affected. It could be homozygous XS because every child is affected. So we have XY, XX. So this could be an X-linked dominant. I'm just gonna say it, X-linked dominant. But look here, if it is X-linked dominant, then every member in the family should be affected. But look at this. So it could be X-linked dominant till we got here. But see, look at it. This generation is skipped. So this can't be X-linked dominant. So what is it? Now let's consider it. What did we say in mitochondrial inheritance is that only mothers transmit. So let's see. Mother is affected. Father is not affected. So mother transmits to everyone. Now mother is affected. Father is not affected. Mother transmits to everyone. Now father is affected. Mother is not affected. But it does not transmit to anyone. So this is nothing but mitochondrial inheritance. And we need to know the examples. Where are the fucking examples? Where are the fucking examples? I remember there was a table. So I think it's not in this, but it should be somewhere else. It should be in a pediatric book, I think, or SPM, I don't know. Or somewhere. It's not in here, but we'll get to the examples later. Because you solve it, there's no point if you don't know what diseases. Okay, now let's see. Mother and father both are not affected. This means the girl child is the carrier. So girl child is the carrier. Interesting. So you see mother and father not affected. So it's not passing down to all generations. So this could be recessive. Only males are affected. Look how only males are affected. So daughters are the carrier. So this can't be Y-linked because Y-linked female should not be affected or be the carrier at all. So this is X-linked and this is recessive because there's generational skip. Next we have Y-linked. See how Y-linked goes. Father is affected, mother is not affected. Now they give Offsprings, male is affected, female is not affected. Now, if not affected female gives normal offspring. So if male is affected, they give, or if male offsprings are present, then the males are affected here. So example is myotonic dystrophy. Now, is it? No, it's not matter. It's color. It's male pattern baldness. Now we have autosomal. Okay, now let's see. See, this is a generational skip. Mother is affected, father is not affected. So we go down. No one is affected in the family. So, but they're still carrier. One of them is still carrier. So now look at this. Daughter is the carrier. So this can't be extended to say why? Because here the mother is affected. Here, as I have said, could it be first? If you just look at this, then you could think it's an extended system. But then you look at the top, at the generation how it started. Mother is not affected. Mother was affected. So this cannot be extended system because then the female has to be a carrier. So this is autosomal recessive. Now look at autosomal. Every child is affected. Every generation is affected. So why does it occur then? Then let's look. Imagine this is mother is totally not affected. She's XX, and this is autosomal dominant, right? XY. So both the genes are affected here. We're gonna take it XX, XY. So everyone are affected, but since mother was not affected, so these all children are heterozygous. So they do have one normal chromosome. They have one normal chromosome, and now we introduce another normal chromosome. So there's like 100% chance everyone are affected. Now next is gonna be 50% chance. Next is gonna be 25% chance. That's how it reduces. Until there's another person with the same disease who comes up and like, eat my balls, and then everyone are affected again. Okay, let's take this. So let's see. Could this be autosomal dominant? Yes, but look at this. Okay, let's see. Let's see. So first the male is affected. The father is affected here, and now there's a normal mother. Okay, why am I saying it cannot be an autosomal dominant? Because everyone have to be affected here. First generation, everyone have to be affected. Everyone are not affected. Only the females are affected. Look at this. So we have an XY and this is an XX. So this is an XY. And this is an XX. Now we're going to transfer XX. So females affected. To the male child, only Y should go, right? So these are normal chromosomes, and this is Y. So children are normal. And again, XX. So yeah, this looks like X-linked dominant for me. It's an X-linked dominant for sure. Yeah, it is an X-linked dominant. Never mind. Now let's go to CTG repeats. Friedreich's GAA, CTG is for myotonic dystrophy, Friedreich's CTG. They won't ask much from here. Disorders. Okay, these are genetic disorders. Prader-Willi versus Angelman syndrome. Both are chromosome 15. What is the difference? Prader, P for paternal deletion. P for paternal, D for deletion. Prader. So paternal deletion, that means what is imprinted is the maternal imprinting is there, which is completely physiological. Normally, yes, paternal deletion is normal. So maternal genes are what gets imprinted. So snore, paternal got deleted. Now Angelman, we have chromosome 15. Now normally where Angelman, mother's angel maternal deletion. So Angelman, so the angel woman got deleted. Now it's an Angelman. So maternal deletion, and what is imprinted is a paternal. So gene is UBE3A gene. Both are chromosome 15. I think so. Trisomy 20 went down, trisomy 13 Patel, trisomy 18 Edward, trisomy 5 is try to chat. Klinefelter is XXY, whereas Turner is XO. Try to chat, we already said, oh, it's P5 deletion, it's trisomy, but it's P5 deletion, IP deletion. Now we have trisomy 22, which is cat eye syndrome. See, this 22, trisomy 21 is down, but trisomy 22 is cat eye syndrome. And just translocation of 922. 922 is CMN, Philadelphia chromosome. Then inversion 16 AML. I think we're almost done, honestly. We're done with general part, and we have to move on to this. Hematology is going to take a while. Hematology is going to take a while. And hopefully we do micro today as well. If you have time, we can start on micro. Micro is not going to take much time. So we still have 1 hour. So I think in 1 hour we are going to finish this, and afternoon we can do micro. I think afternoon should suffice for micro, honestly. I think the pace is pretty good. We finished surgery, we finished medicine, we finished a part of OG, we finished a part of SPM. We're gonna finish path now. We have still 18 days. I want an entire week for just MCQs, nothing else, just solve MCQs constantly. I want to do at least 500 MCQs every day with learning from these MCQs so that I don't fuck it up later. Let's see. Our target is 45 seconds, 42 seconds per MCQ. Maximum a minute, not more than that. So imagine there are 500 MCQs. It's gonna take approximately 500 minutes or 450. Let's take 450 minutes. So how much is that? 6. It's gonna take almost 8 hours. Yeah, 8 hours every day of MCQs. We're gonna die. But winnable, we can do it. Come on, nothing's too hard. Nothing can be too hard. Plus, MCQs is the one thing I can do passively, not like active reading. So inversion 16 is seen in AML. What was translocation? CML is translocation in 922, and inversion 16 is AML. So fish hybridization is in BCR ABL translocation as in CML. Trisomy 21 already said, plus trisomy 21 which is downs, then amplification of relatively. Okay. So what is array-based comparative genomic hybridization for multiple mutation in single test? Now we have gene mutations. DCM, Titan gene element. HCM we already said is beta myosin heavy chain, ARBCM, pachyglobin desmin, Naxos syndrome. Now we have SC squamous cell lung cancer, P53, keratin pearl, adenocarcinoma, EGFR, KRAS, lactic patterns, small cell P53RB, chromogranin synaptophysin, miniature disease, TGF alpha, A beta lipoprotein, acanthocytes, and TP. I think it's pretty much discussed everything already yesterday. Yeah, I told you, general path is not gonna take long. It's a little confusing, but we already discussed a lot of it before, so. Oligodendroglama is 1P 19Q code L. Seminoma isochromosome 12P, papillary thyroid BRAF red, follicular, medullary is red, follicular is RAS is most commonly. And PNHP for pig up. Oh, there we go. We found it. Yeah, these are the examples. So autosomal dominant disorder, the mnemonic is a dominant, very funny human. So A for autosomal dominant polycystic kidney disease, ADPKD. D for myotonic dystrophy, O for osteogenic imperfecta, M for Marfan syndrome, I for intermittent porphyria, N for neurofibromatosis type 1, A for achondroplasia. there's an other N, which is for neurofibromatosis type 2. Then T is tuberous sclerosis. Then we have very funny human. V for one Willebrand disease, VHL. F is for familial hypercholesterolemia and FAP, and H is for Huntington's chorea. So a dominant, very funny human. AD, autosomal dominant, a dominant, very funny human. So what is the mnemonic? A is for ADPKD, D is for myotonic dystrophy, where D is the D. O is osteogenic imperfecta, M is Marfan syndrome, I is intermittent porphyria, and both the N's are for neurofibromatosis type 1 and 2. A is achondroplasia, T is tuberous sclerosis, V is Willebrand and VHL. F is familial hypercholesterolemia and FAP, and H is Huntington's chorea. Now we have autosomal recessive. Everything else is pretty much autosomal recessive. So past wala college hai. I don't like the mnemonic. I mean, I don't remember the mnemonic very often. I don't remember mnemonics very often. So we have phenylketonuria, alkaptonuria, sickle cell disease, Wilson disease. So how I remember is everything that's not AD has to be in AR. There are very few XLD and XLR. So as long as we remember these, very important. It's easy to remember XLR. So XLR, and very rare this is an XLD. So everything else has to be AR. That's how we remember it as, like phenylketonuria, alkaptonuria, sickle cell disease, thalassemia, Wilson disease. Alpha-1 antitrypsin deficiency. A is for albinism. Then we have lysosomal storage disorders. Then we have cystic fibrosis, adrenal hyperplasia, glycogen storage diseases, hemochromatosis. Now, it's very easy to remember XLD. XLD, we have RIVA, which is Rett syndrome, incontinentia pigmentae, vitamin D resistant rickets, and Alport syndrome. Whereas XLR has Wiskott-Aldrich, hemophilia A and B, color blindness. Remember I said muscular dystrophy, myotonic dystrophy, and AD, but Duchenne muscular dystrophy is an X-linked recessive. Then they have Leach-Nyhan syndrome, Fabry's disease, G6PD deficiency, Hunter's disease, and Leibow's disease. Duchenne muscular dystrophy is common among the King Victoria family line. They're all purebreds, so every male just dies. They're the females. Every male dies after the age of 20. Now let's go to hematology. Hematology, the most dreaded. Let me drink some coffee. I'm just thinking this is a one again. Well, I think that's all. I already read hematology before multiple times, so let's take that. Okay, stranger pages. Yeah, honestly, I'm gonna skip RBCs because I'm totally fine with it. Too tired of reading RBCs. They're not gonna get into this detail. They're never gonna get this detail. You don't ask very simple questions from RBC. It's close to this really. Oh god, I hate this table. This is my nightmare, guys. And pathology, this is my nightmare. This fucking flowchart is my nightmare because I just keep forgetting every fucking time, even though I wrote it multiple times. So we have pancytopenia. You do a clinical examination. There's hepatomegaly or there's no hepatomegaly. If there's hepatomegaly, you see if there's hypersplenism. If there's no hypersplenism, there's hypersplenism. So, 1 second. I'm sorry. No. You do a bone marrow aspirate. I already said we do a hepatosplenism, right? It is says for hypersplenism. Okay. So there's hepatosplenomegaly. Now you do a bone marrow biopsy. So what do you get in the bone marrow? So there's one chance where you get hypercellular bone marrow with normal hematopoiesis. There's one is dry tap, one is infiltrative diseases, and second is hypercellular with abnormal cells. So we say hypercellular with normal cells, we say hypercellular with abnormal cells, we say dry tap and infiltrative disease. So normal hematopoiesis is only hypercellular, then it's hypersplenism. Hypersplenism increased destruction of your blood cells. So there's going to be pancytopenia because of that. Next, we have hypercellular with abnormal morphology. Abnormal morphology, that we look for what is present in that abnormal morphology. Are there immature cells or blast cells? Are there mature cells? If they're immature cells, then you do the staining respectively. If there's or rods, if there's abundant granular cytoplasm, if it's MPO positive, then we look for fish. So fish positive, it's AML. If it's fish negative, so you do PCR, you look for genes. If there's unexplained mutation, then it's AML with mutation. If there's no mutation, then it's AML without mutation. So basically, if MPO or rods are present, it is AML. But based on fish and PCR sequencing, you see what type of AML it is. Now, infiltrative diseases, that means there's a metastasis. Dry tap is nothing but fibrosis, dry tap fibrosis. Next, we didn't finish hypercellular normal cells. We did immature cells. Now we look for mature cells. If they're mature cells, look for, is it myeloid lineage or is it lymphoid lineage? If it is myeloid lineage, you do PCR, look for mutation or fish, and lymphoid lineage, you do a flow cytometry. Now we have no hepatocytopenia. You do a distant pancytopenia. Now we do a bone marrow aspirate. Now we have, again, you have hypercellular with dysplasia. We have hypocellular or dry tap, and we have hemoglobin thrombosis. Now, if it's hypercellular with dysplasia, then you do a fish. It turns out to be MDS. Now, if there's hypercellular or dry tap, it's aplastic anemia. And if it's hemoglobinuria or thrombosis, it is PH, paroxysmal hemoglobinuria. So let's go through this once again. Now we have a patient with pancytopenia. Let's check if he has hepatosplenomegaly or no hepatosplenomegaly. If he has hepatosplenomegaly, both you do a bone marrow aspirate or biopsy. So in case of hepatosplenomegaly, his cells are hypercellular but normal morphology. That is just hypersplenism. If it's hypercellular with abnormal cells, you look for if it's mature or immature and mature cells. If it's immature cells, you look for the morphology. If it has abundant granular cytoplasm or rods, MPO positive, it's AML. Now you do a fish. If it's fish positive, AML with cytogenetic abnormalities. If it is fish negative, it's without any cytogenetic abnormality. You have to do a PCR. If it run X1, MP1, and SEPRA gene, it is AML with mutations. If no mutations, then it's AML, morphological AML. Now, we didn't go to the second part of it. So morphology of cells in immature blood cells. The patient is the scan cytoplasm, no rods, and special scene is not MPO, but it's PAS. If it's PAS positive, then you do a flow cytometry. Flow cytometry, look for the mutation. If it's CD3, CD10, TDT, CD34 mutation, that is TOL. If it's CD19, 2010, TDT, and CD34, it is BO. Now, no hepatosplenomegaly. You do a biopsy. If it comes hypocellular dry tap, it is aplastic anemia. If it comes hypercellular dysplasia, it's an MDS. And if it is hemoglobin with thrombosis, it is PNH. Now, so that is pancytopenia with bone marrow biopsy. Now we're looking at lymphadenopathy. If there's a lymphadenopathy, you do a clinical examination on microscopy. So there's generalized lymph nodes. In northern women, there's extranodal positive. There's normal neoplastics, numerous neoplastic. What the fuck is normal neoplastic? Numerous neoplastic cells. So that is non-Hodgkin. But if there's regional lymph nodes, if there's external, there's no external lymph node involvement, there's occasional neoplastic cells as Hodgkin. So let's go into Hodgkin first. So Hodgkin lymphoma, you look for. So Hodgkin lymphoma common is for everything is it's CD15 positive, CD30 positive, CD20, and CD45 positive. Now, if it is CD20 and 45 plus positive, then it is Popcorn cells or lymphocyte rich. So it's nodular lymphocyte predominant Hodgkin lymphoma. If it's regional blood cell positive with CD15, CD30, then it's classical Hodgkin. Now let's look into non-Hodgkin lymphoma. Non-Hodgkin lymphoma based on what is positive. If it's CD3 positive, it's T. And if it's CD19, 20, as we saw before, it's B NHL. So B NHL, now B NHL, you look for CD5. If CD5 is positive, CD5 is positive, then, or negative. So if CD5 is positive, then you look for CD23. CD23 is positive, it is BCLL, or if it's CD3 negative, you look for cyclin D1. Cyclin D1 positive is mantle cell, cyclin D1 negative is cyclin D1 negative mantle cell. So if they mention cyclin D1, it's always mantle cell lymphoma. If they mention CD23 positive, then it is myeloma. CD23 positive is myeloma. Now, what did we say? Non-Hodgkin, if CD1920 is BNHL. BNHL, again, you look for CD5 negative. Now we're looking into CD5 negative. CD5 negative, but CD10 is positive. So what do we say? CD3, CD10, you need to be careful. It could be TNHL, but here we're saying specifically saying CD5 is positive. We're saying CD19. There is also CD1920. CD1920 is always specific for BNHL. If there's no CD19, then we can think of TNHL. But if it's present, then it's always positive, irrespective if there's CD3 positive. Now, if there's CD10 positive, then it's BAL. If CD10 positive, TDT is negative. TDT positive is BAL. TDT negative. Again, we're going back to Panzer table. So look at it. TDT positive is BAL. Right? If TDT negative, it's germinal B symptoms. If B symptoms are absent, then it's follicular lymphoma. If B symptoms are present, look at Ki67 index. If it's more than 95%, it's Burkitt lymphoma. It's less than 95%, it's diffuse large B cell lymphoma. Next, we have CD10 negative and TDT negative. If CD10 negative, TDT negative, then it is likely marginal zone myeloma. Okay, this is a little confusing. I mean, more than a little, it's a lot confusing, but there are certain keywords that you have to remember for each. Like example, what did I say? Cyclin D1, if they mention anywhere, it is mantle cell lymphoma. Irrespective of what you read, if there's cyclin D1, it is mantle cell. If they even fucking remotely mention cyclin D1, it's mantle cell. And Hodgkin's is pretty simple. They have to measure the popcorn cell, regional lymph nodes, extranodal involvement, regional blood cells. Easy to remember. Now, generalized is always non-Hodgkin's. Then again, you look for CD1920. Same as how we read before. 1920 is always B. And T cell is always CD3, CD10. Now, CD10 is present in BHL, then that means it's a BOL. If TDT is negative, then it's you check for B symptom. If TDT and CD10 are negative, then it is myeloma. Now, B symptoms present, B symptom absent. If B symptoms are present, look for Ki67. Ki67, always they have to mention Ki67 if we're talking about Burkitt or large B cell lymphoma. If it's more than 95%, then it is Burkitt, and if it's less than 95%, it is diffuse large B cell lymphoma. Now, B symptom absent, but they said BCL2 positive with low Ki67. If they mention specifically low Ki67, then it's follicular lymphoma. Now let's go to acute lymphoblastic leukemia. Increased lymphoblasts with more than 30%, AML, LF2 blast more than 20% bone marrow, or any genetic abnormality in myeloblasts except T922, which is CML, or KEBRA mutation. When you read KEBRA mutation, we don't need AML, right? Wait, what? Okay. Okay. Except 322. Except 322. And Kebra mutation. If there is Kebra mutation and it is AML. Oh, that was just grammatical error. Then we have polycythemia vera. Major polycythemia major polycythemia. Okay, all three major or first two major and minor criteria. So major is hemoglobin more than 16.5 or in men or more than 16 in women. HCD more than 49, more than 48. Hyperciliary bone marrow erythroid predominance, JAK2 mutation. Minor as low erythropoietin levels. Okay, we're almost done, honestly. There's very few left. This is pretty simple. Multiple myeloma cells. M-band should be present in multiple myeloma, CRAB, hypercalcemia, renal failure, bone lesions, plasma cell leukemia, peripheral cells more than 20%, Hodgkin lymphoma, ABVD, non-Hodgkin, you give R-CHOP, BL or CAR. I pretty much know most of this. I just quickly give us a look. Hairy cell leukemia, asymptomatic waiting horse. If symptomatic, you give cladribine, bifranibine. AML, subretinal dorsal acute problematic leukemia, all transitory acids. CML, apatinib, glycemia, phlebotomy, hydroxy. Okay. Berkeley, classical EPV, flows of pathology. We already went through this, the tennis racket appearance. Yeah, I think we've pretty much the secondary blood disorder is not really important. Okay, I think we're done. We're done. We're just so quickly. I did not expect to finish in less than 30 minutes. Yeah, that's because we skipped RBC and platelet, which I'm kind of already thorough with. So, yeah, that was a really short stream. That was a fucking short stream. Let's rate someone and I thought afternoon I'll just take a break from streaming. I'll read, but I'll read passively. I just want to play some League as well. But now if we're gonna stream again, we're gonna play League. So thank you so much for joining, guys. I know it's a stupidly short stream, but it had at least helps me. It helped me concentrate. So let's see who is anyone playing League. Oh, Ren is streaming. Oh, Trin is streaming. Okay, we're gonna rate Trin. Thank you so much for joining. Bye bye, guys. Hop onto the rate train.